I'm Steve Shaha, and I have two affiliations. One is as a professor at the Center for Public Policy and Administration, and the other is as the principal outcomes consultant for a group called Allscripts.
So, we're obviously here today at Health Informatics event. What do you see as being the biggest challenges at the moment in the world of health informatics?
In the world of informatics, there are a lot of data we can analyze, and a lot of people do a lot of analyses. Usually it's leadership looking for problems. Who's the doctor that isn't doing what he should be, or the nurse that's causing problems? So we call it informatics, but it's really espionage or bad apple management is maybe a fair term. No, the purpose of informatics is to help clinicians understand how to make better decisions compared to what they're currently doing. And then the cases with all other clinicians on staff, nurses, respiratory therapists, so that everything works better, so that patient outcomes are as good as they can get and the costs of providing care are as good as they can get. And nobody can do that if they're in management. Only practitioners can make better outcomes happen and make costs go down. The leadership only can provide support and insight. Only doers can do. So as you can tell, I'm a huge advocate of clinicians.
And what do you think organisations like BCS can or should be doing to help?
First of all, to help people that can get data have better insights into the kinds of answers, the kinds of questions they should ask, and the kinds of answers they should be getting. Again, with my huge biases towards help clinicians help patients. The other thing is, we ought to be more progressive, not that it's not being progressive in NHS, and electronic patient records are the next generation of computerization. We used to call them information systems. Unfortunately, most of them are just repositories, giant oil drums that we put data into, but we can't ever get it back out to analyze it for informatics purposes. And if we do, it comes out as rote reports. There are these 20 reports you get, and that's it. We ought to be able to query those data, to access them, to withdraw them ad hoc. Ask a question and not only ask it, but if we like the kind of answer we're getting, make that a routine report that I can run monthly or quarterly or even daily or weekly. If we're not looking for electronic patient records where we can reach into them, we're going to just end up with another generation of paper records that just happen to be computerized. And informaticists need and create information. So we need to find electronic patient records where we can queue and query, grab stuff out, analyze it, and then when we find something new, change the system to give the correct kind of information to acting clinicians so they can actually do something better, different. And I always remember that adage. The definition of insanity is doing the same things and expecting a different result. A good electronic patient record can help us innovate without the vendor telling us what we should be doing. Just because it works in New York or Auckland, New Zealand, doesn't mean it's right for us. Just because it works in Liverpool doesn't mean it's right for Portsmouth. Different populations, different clinicians, different organizations, the location of different pieces, imaging, lab, and the way we commute. Anyway, we ought to be able to customize it to where we are. That means I can change the electronic patient record within my own organization and then draw information, then get something and then change it again and have that kind of a circle. I did a lot of talking. Did it make any sense?
That's fine.
Oh, and I'm a huge advocate of the purpose of an electronic patient record is not just to replace paper. We could have done that with Word. And I think we want to be a little bit beyond just word. An electronic patient record does not supply us with the progress that we need until it helps clinicians make better decisions to help patients get the right kind of care. And both of those require searches that informaticists can get and analyze, and then the programmability and adaptability of the electronic patient record to meet the evolving and innovative needs.
A couple of other questions for you. I mean, do you think at the moment it's a good time to be a health informatician? What's the state of the profession at the moment? Is it in a good place?
If my son were asking what to be, I would tell him either be a clinician so you can always make great decisions and heal, which is a magic skill, or be an informaticist, because you can now help clinicians do better, which really means help organizations do their mission better. So I think informaticists are a key element in the future of healthcare, and they already are. They just haven't been given access to the medical records the way we need them to be able to. So I think it's a great field.
Of course, that access comes with a lot of responsibility, and a lot of patients, understandably, have been a bit reticent about giving their data to people who are strangers to them. So where do we get it into the realms of that problem of big data, which being able to use it but without making it apparent that it's Mrs. Smith from number 9 here? Or
fabulous question. And the idea of secure data and anonymity and protection is absolutely critical for patients, but if I can even go a step further, it's critical for doctors. Otherwise, we end up pointing fingers at who's good and who's bad, instead of say, what's a current way and what would be perhaps a better way, because someone's already doing it. Why don't we all try to do it that way? So privacy is mission critical, but we for years have analyzed data that is blinded. And when we say blinded, that means we don't identify the patient or the clinician. We identify patterns, and that's 10 or 100 or 1,000 patients that got some certain disease, and it was cared for in this certain way, and it was different than that way, and this way had better results. So what clinicians were involved? We can blind all of that. I've got some great case studies on the power of providing blinded data both to physicians and to patients. It helps them see a better way and feel not trapped or coerced or punished, which is, I think, critical to both clinicians and patients in terms of doing something different and something better.
While I've got you here, what would you say are the main differences between, say, health informatics in the UK and health informatics in the US?
And I actually spend time with informaticists in New Zealand, in Australia, in Singapore, in the Middle East, in the Emirates, in England, in Canada, and in the United States. And it's interesting, none of these has the same kind of information that they record. And when they record it in the EPR, they record it for a different motive. And I hate to say it this negatively, but here we record it in the United Kingdom to help clinicians, help patients, and also to make budget and to figure out, are we doing the right numbers and is it costing less? In America, similar, but a little more on the revenue and profit end. And I'm not saying anybody's evil. It's different survival strategies that are required. The best thing would be if informaticists help clinicians make better decisions. Those decisions will become increasingly more cost effective because the patient will be healed more quickly, shorter lengths of stay, and less intervention and interaction and testing to meet the same need, potentially even better. So we can save cost if we help clinicians. If leaders of organization think they can do it themselves by dictating, that's sad. And they don't do that for their own mother or their own child. They want real clinical help. Well, why can't you treat the other patients like that? We should help clinicians do clinical more wisely or more informed. And the informaticist's role is exactly that. My role is to inform so that decisions are made optimally without pointing fingers or punishing or even rewarding. And so blinded data, which was part of your first question, is absolutely critical. I have some great case studies on that, the impact of blinded data.